Well, she's not gonna be with the sheriff. Yeah, she didn't. It's very first semester. She has 5 classes and she was out. The second semester, she. Yeah. Hi, how are you? Good, how are you? You have the code? Yeah, all right. Good, how are you? How are you? She is actually.
We don't want to, no, we don't work on money, don't do the name, but. Yeah, Keith. Did you want one of us to do the role or are you taking that? Yeah. You're done. What you got? That's super.
I don't know, like, no, it's right here.
Yeah.
For the CPR? Yes.
Let's see.
Let me know if you need me to do it. I'll just follow you. Yeah. And then, everybody can share screen. I'll have mine here. Click it. And I have my clicker.
Okay, sounds good. Yeah. Yeah, yeah. So you can deal with that.
Yeah. Let's go back.
Acts first, right?
Well,
Yeah.
yeah. So, I mean, he's down to close, but. Yeah.
I'm gonna make an executive decision and pass this road.
Didn't.
Yeah.
I'm gonna have to get up there during, because I'm giving a presentation. I'll have to get up there, so I'm just gonna. We can just push. I'll just push it back.
Yeah, you guys.
Just push it back.
You want to?
Yeah, because this one's double, keep it.
Yeah.
Okay. Actually,
Thank you, Courtney.
Yeah, you bet. You want your hour or double?
that's what I'm figuring out.
We'll do it for the fire season. Really good. There you go, perfect. Even better. If anybody needs a time on. I know, sure.
Yeah, well, this was like right up here. And I know one moment, one point, I'm gonna have to go up to the podium. Or the right turn, and
Oh, that's great.
it's either I walk all the way down or. I'm doing it for me.
Yeah.
I can-
You're up. There you go.
But also help you out too.
Yeah. Infrastructure time, reach out to all, maybe.
Yeah. it was very- Yeah.
And then have this roll call this year. So some of the month and.
I know. One time, I don't know. She doesn't say it. One time. Yeah. One time, Alpine County, probably in total. The BHAB is very clear. The BHAB is 300, it's all red, and there's LA, it's all red, moving there. Water and they're all right here.
It was in chaos, but, you know, new chaos, like, different chaos. Yeah. It's a bit busy morning. Good morning.
I think, I see a start.
See you.
All right, I'm right behind you.
Last Monday, man.
Yes. Yes.
I'm not too grateful.
Yeah, I will. Let's see.
Yeah.
But again, you got to.
We'll see. I don't think I can fight this.
Afternoon. I thought they had my right.
Yeah.
Probably supposed to. Didn't say it.
Might not be the voice.
On the occasion, there's the I understand back over politics.
I know better than you do. I want to tell you that. About 30 properties I know.
Yeah, he's been saying.
Yeah, yeah.
There's back up. How are you? Yeah. Nice. Yeah.
So do you.
It's never seen for a while.
Two more.
She's pristine, isn't she? That's cool.
Yeah, it's actually.
They're all fighting up there.
We're just having technical difficulties.
Oh. That's true. Yeah.
I think it's just worded so. If it's like, see how it's like.
Yeah. But.
This is it.
Like that.
So it's gonna be, that's why I did it. Not because it's just all, you know, breaks up.
This is my warning.
It's okay.
Good afternoon, everyone. Thank you for being in order. My name is Michael Rowe. Are you ready, Jackie? Sorry.
Yes.
Okay. I'm Michael Rodriguez, calling the meeting to order. Before we get any further, if the interpreters can instruct us on the interpretation process.
Good afternoon. Thank you for being here. We'll be happy to interpret simultaneously for all of you. If you're here in person, as the interpreters for a headset, just raise your hand and we'll bring it to you. If you're in Zoom, go to the bar that shows your language of preference and click on your language of preference, even if you're bilingual. Muy buenas tardes, gracias por estar aquí con nosotros. Mi colega Moira y yo, Lourdes, estamos aquí para la interpretación simultánea de la reunión. Si están aquí en persona, pasen con nosotros y les daremos un aparato receptor para que escuchen. Si están en Zoom, por favor, pasen a la parte inferior de su pantalla y escojan su idioma de preferencia, aun si son bilingües. Gracias.
Good afternoon, Mr. Espinosa. Mr. Espinosa, can you please take roll?
Right. Soledad Paragon. Present. Nancy Borcher.
Present.
Jane Brooking. Present. Kevin Paricci. Here. James Espinoza, present, District 4. Letter Representative. Genevieve Flores Harrell.
Present, Sean.
Cheryl Heitman.
Present.
Carol C.J. Keaveney.
Present, District 2.
Supervisor Matt Lavere. Here. Nomi Marufo.
Here, District 3 Prevention Committee.
Diane McKay. Dan McKay,
I believe she's excused. She notified us last meeting that she wasn't.
Jennifer Morrison. Jennifer Morrison. Sean Pusey,
Present, law enforcement representative.
Dahlia Robkin,
President, District 4.
Michael Rodriguez,
Present, District 5.
Elizabeth Stone. I think I saw her online.
Oh, sorry. As you kind
I'm participating online today, Michael. I mean, James. This is Elizabeth.
Marlon Forrest,
Here.
Liz Warren. Liz Warren, present. Janice Garner is present.
So it looks like we have a point, thank you. And as an aside, my name is Michael Rodriguez, I'm Chair Emeritus. Chairing the meeting, today because Janice Gardner could not be here. And so welcome everyone, folks that are here in person as well as folks that are here, remotely. Moving on to item 4. Have there been, Jackie, have there been any requests for emergency circumstances?
No.
All right, moving on to item 5, approval of the agenda. Can I get a motion, please? So that's a motion by Kevin Carisi, second by TJ Keaveney. Any discussion? All right, can we get a vote, please?
Call folks that we know are interested.
No.
All right, moving on. Nancy Borchard,
President, oh, yes. Sorry.
Kevin Ricci, yes. James Espinoza, yes. Genevieve Flores Harrell,
Yes.
Cheryl Heitman,
Yes.
Carol Keaveney,
Yes.
Supervisor LeBeer,
Yes.
Nomi Marufo,
Yes.
Sean Pusey,
Yes.
Dahlia Robkin,
Yes.
Michael Rodriguez,
Yes.
Marlon Torres.
Yes.
Motion carries. Moving on. Okay, moving on to item 6, approval of February 26, 2024 minutes. Can I get a motion, please? Move approval, Chair.
Second.
So that is a motion by Supervisor Matt DeVere and a second by Cheryl Hyman. Any discussion, corrections? Not seeing any. All right, can you get a vote, please?
Yes, Nancy Borchard,
Yes.
Kevin Clarici,
Yes.
James Espinoza, yes. Genevieve Flores Harrell,
Yes.
Cheryl Heitman,
Yes.
CJ Keaveney,
Yes.
Supervisor LeBear,
Yes.
Nomi Marufo,
Yes.
Sean Pusey,
Yes.
Dahlia Robkin,
Yes.
Michael Rodriguez,
Yes.
Marlon Torres.
Abstain.
Motion carries. Moving on to item 7, public comments. The lead received 1 request for written public comment. So let me go to that first before we entertain request for public comments. I see 1 remotely from Carol Shelton, and if you were here in person, if you can let us know if you wish to make a public comment at this time. There'll be other opportunities as well. Thank you. So this written comment was submitted on Sunday, March 17th from Pete LaCollette. His message says, the most recent update showed Proposition 1 with 50.2% of the vote, leading by about 21,000 votes. with $500,000 ballots left to be counted statewide. And that was as of March 15, 2024. Ms. Shelton, followed by Elizabeth Stone.
Thank you. My name is Carol Shelton, and I am proud to serve as the Vice President of the Autism Society of Ventura County, as well as a member of our Advocacy Committee. Sorry, my phone. Sorry. Happy Developmental Disabilities Awareness Month. Happy Neurodiversity Celebration Week. And next month, we will celebrate Autism Acceptance Month. I wanted to share current CDC statistics about autism. The CDC's Autism and Developmental Disabilities Monitoring Network, or ADDM, estimates that 1 in 36 children has been identified with autism spectrum disorder, or ASD. 1 in 36. Let that sink in. Now on to my comments. Autism Society of Ventura County is dedicated to advocating for local public policies that enhance the lives of people with autism, both children and adults. As a mission-driven organization, we strive to represent and support individuals and families affected by autism, while also collaborating with other local entities to uplift all marginalized members of the Ventura County community. Our advocacy committee, developed to further our mission, comprises autistic individuals, family members, and community advocates who convene regularly to examine the agendas of decision-making bodies across Ventura County. Our overarching goal is to foster connections and cultivate partnerships with leaders in Ventura County, all while advocating for the rights and needs of those with autism and beyond. If you have any questions about ASVC or our advocacy committee, please email me at Carol, CAROLE, @autismventura.org. Thank you so much for your time.
Thank you. Elizabeth Stone.
Hi, good afternoon. I've been spending time in multiple counties, expanding my knowledge of services. Several people have asked me about the Director of Healthcare Services for the county position that's posted. And I'm hoping that we can learn today if, in fact, Barry's retiring and what the date is for that. And if so, that leaves 2 major positions that are going to be impacting people that receive behavioral health care services, the director of VCBH, and as well as the entire public health department of the county. And as we've seen, and again, in the director's report, there's a lot of things where the county is really kind of behind or just at what's being mandated and not really having a vision of where the state's asking us to go. So I really hope that people, especially that have decided to spend their time serving on this board, encourage choosing leaders in these positions that really have an investment in moving the county forward in the ways that we can see that the state is hoping for, that also really mirror best practices that many of us have been sharing studies about for several years. I'm going to stop with that, and then as the items come up on the agenda, make more comments. But I am hoping to learn definitively, not by rumor, what exactly is happening with the director of the healthcare, and if Barry is retiring, and if so, when. Thank you.
Thank you, Elizabeth. Are there any other requests for public comments at this point? All right, not seeing any. Moving on to item 8, and I'm going to pass the gavel over to James Espinosa.
You're gonna be presenting marker.
Yes.
The microphone warmed up here. Good afternoon, everyone. I'm James Espinosa, District 4 Representative appointed by Janice Hartman. I have the distinct pleasure and honor of introducing Michael Rodriguez, who will be giving our time-served presentation today. Briefly want to intro him as requested. Michael Rodriguez is a Ventura County Chief Deputy Public Defender who manages the juvenile mental health, probation conservatorship, immigration, criminal, and criminal justice mental health units. Mr. Rodriguez has been an attorney with the Ventura County Public Defender's Office since August of 2004. He has tried numerous serious felony and misdemeanor cases and worked in juvenile delinquency, drug court, and mental health. Mr. Rodriguez is Chair Emeritus of the Ventura County Behavioral Health Advisory Board and Vice Chair of the California Association of Local Behavioral Health Boards and Commissions governing the board. Prior to joining the Public Defender's Office, Mr. Rodriguez was a directing attorney for California Rural Legal Assistance's Oxnard Basic Office, where he managed a busy legal aid office while representing indigent clients in civil rights, landlord-tenant disputes, public benefits, and employment cases. He was a legislative staff attorney for the Mexican American Legal Defense and Educational Fund, also known as MALDEF, in Chicago, Illinois. During this tenure at MALDEF, he collaborated with Congressman Luis Gutierrez and then State Senator Barack Obama. Mr. Rodriguez earned his Juris Doctorate from Pepperdine University School of Law in December of 1990 and his Bachelor of Arts in Political Science from California State University, Northridge in May of 1988, a fellow Matador. Go Matadors. He is a product of Ventura County Public Schools. Michael Rodriguez is married and a proud father of 3 amazing individuals. Thank you, Mr. Rodriguez. You know how to go.
Thank you. Good afternoon, everyone. Once again, I'm Michael Rodriguez, I'm the Chief Deputy Public Defender. It is unconstitutional for the government to prosecute an accused person who is legally incompetent. CPP Robinson, 1966-86, Supreme Court, 836 and 838. This shapes or provides the entire lens in which this entire process, which I'll discuss about, which I'll give a very basic overview today, derives from, is that it is unconstitutional for the government to prosecute an accused person. It's violate to do otherwise is to violate the due process clause of the 14th Amendment. Per Penal Code Section 1367, an individual accused of a crime. Whoops. Hold on one second, let me revise this. Is this screen sharing?
Yeah.
Okay. An individual accused of a crime. Give me one moment. We're gonna try this again. We're trying to screen share from my computer, so I apologize for. Seeing a request. Sorry about that. Anyways, going to penal code, section 1367, an individual accused of a crime who is mentally incompetent, if as a result of a mental disorder or intellectual disability. All right, let's go back to square one. Jackie, let's go back to youth care screen, and I'll just tell you next slide.
Okay.
My clicker's not working for whatever reason.
It's okay with the screen.
All right, back to this slide, and I apologize once again, folks. Per penal code section 1367, an individual accused of a crime is mentally incompetent. If as a result of a mental disorder, intellectual disability, they cannot understand the nature of the criminal proceedings, including the roles of the people involved in the process. This includes the roles of the judge, prosecutor, and defense counsel. Or they cannot assist their attorney in the defense in a rational manner. And so some of the things we look at with respect to this alternative element is whether they have the factual and rational understanding of the proceedings, whether they have the ability to assist in preparing their defense, including whether to take the witness stand, whether to waive trial by jury, whether to decline or to cross-examine certain witnesses, whether to put on the defense, and whether to raise one or more affirmative defenses. Next. Once a doubt is declared regarding competency, criminal proceedings are suspended. And before I go further with this, doubt is declared by generally one or two people, the judge or defense counsel. And now more often than not, it's by defense counsel after we've met with our clients and based upon our impressions during our initial interviews, whether someone appears that they are incompetent or not. Now, this isn't a finding. We are not experts. We are not making the finding. We are just raising a doubt or declaring a doubt as to whether someone is competent or not. But once a doubt is declared, criminal proceedings are suspended from the stage where they were at the moment the doubt is declared. So if doubt is declared at arraignment, it's suspended at arraignment. If it's suspended at the time of pretrial, it's suspended at the time of pretrial. Once proceedings are suspended, the court appoints a psychiatrist or licensed psychologist to examine the individual accused of a crime. Now, as you see, there's going to be different pathways with respect to competency. And so if we suspect developmental disability, and oftentimes it's based upon our interview, it's also our interactions and communications with families or their caregivers. So if we suspect developmental disabilities in play, then the court will appoint the regional center director or their designee to conduct the evaluation as opposed to a licensed psychologist or a psychiatrist. Next slide. And then so what the next step of the process is that once the evaluator or diagnostician completes their evaluation, they submit their report and findings to the court and serve copies of the report to the prosecutor and defense counsel. At this point, the prosecutors and defense counsel have one or two choices on those reports. We can stipulate as to those findings, the findings regarding competency or incompetency, or we can, either side can request a jury trial. Now, since criminal proceedings have been suspended, the jury trial would be solely on the issue of competency. Would have nothing to do, there would be no adjudication or no trial of any of the charged offenses. And so if the individual is found mentally competent, the criminal process resumes from the stage in which they were suspended. So if it was suspended at arraignment, then we go back to arraignment. If it's suspended at pretrial, we go back to pretrial. If the individual is found mentally incompetent, criminal proceedings remain suspended unless competency is restored. Next slide. Now, there are three different pathways at this stage as far as incompetency or competency to stand trial. There's misdemeanor pursuant to Penal Code Section 1370.01, felonies, Penal Code Section 1370, developmental disability, Penal Code Section 1370.1. Each one of these have three distinct pathways with respect to how the process is going to play out. And so first, let's start with misdemeanors. Next slide, please. Well, actually, let me step back before we go to misdemeanors. I want to remind folks is that the overall purpose of this process is to prevent the prosecution of individuals who are legally incompetent. Measures include restoring competency and determining whether there's a reasonable likelihood that competency can be restored. Now on to misdemeanors. Next slide. In misdemeanor cases, there is no competency restoration. Per Penal Code Section 1370.01B, the options are a referral to mental health diversion, and in this case, the court must hold a hearing within 30 days of their incompetency determination regarding suitability and eligibility for mental health diversion. 2 is assisted outpatient treatment, or AOT, pursuant to Welfare and Institutions Code Section 5346, subparagraph A. Here, the court must conduct an eligibility hearing within 45 days of the referral to AOT. If the individual is accepted into AOT at this point, then the misdemeanor case is dismissed. Next is LPS conservatorship pursuant to Welfare and Institution Code Sections 5350 et sec. And an LPS conservative petition, in this case, must be filed within 60 days of the referral. If the court orders an LPS conservatorship, then the misdemeanor case is dismissed. And then the other one listed is care court. Right now, this is not an option. We are in the second cohort with respect to the CARE Act. Care court will not be up and running until the end of this year. However, since likely this presentation won't occur at the end of the year, I wanted to include it because in the penal code, this is one of the options. Since we're in cohort 2, it's not in play now, but by the end of the year it will be. And so pursuant to Welfare and Institution Code Section 5978, the court must conduct a CARE Act hearing within 14 days of the referral. And again, like AOT, LPS conservatorship, in care court, if the person's accepted into care court, the misdemeanor case is dismissed. And then finally, the court has the option, generally at the as far as at the motion of primarily defense, but occasionally prosecutors will move to dismiss the case pursuant to Penal Code Section 1385. Now on to felonies. Next slide. Felonies is more complex as far as what goes on here. Felony cases pursuant to 1370, they were referred to. Now remember, this is all these sections that I'm talking about: misdemeanors, felonies, and developmental disability. There's already been a finding of incompetency. So someone is legally incompetent. The court has made a determination that the individual is incompetent to stand trial. So at this stage, for felony cases that refer to MHM of Ventura County Competency Restoration Placement Recommendation, if they are in custody, the individual remains in custody pending placement and pending transportation to their placement. And so the options are outpatient, which is extremely rare, placement at the Department of State hospitals, such as Atascadero State Hospital or Patton State Hospital, or jail-based competency restoration, which takes place inside Ventura County Jail, in the 10 unit, I believe. Is that correct? Yes. Or the person may be referred or placed on mental health diversion pursuant to Penal Code Section 1001.6, which is also very rare at this stage. Next page. If competency is restored, criminal proceedings resume at the stage from which they were suspended. Again, if they were suspended arraignment, that's where the case resumes. Pre-trial there. And so what we're talking about here is that person has participated in competency restoration treatment, whether it was at the Department of State hospitals or jail-based competency or community-based. And if there's an opinion as to what will happen at this stage is that the treatment provider will submit paperwork called what's entitled a certificate of competency. It will lay out the justification for whether someone is competent. And the things that they're looking at is, one, do they understand the proceedings? All too often, frankly, is that when we get these certificates of competency, is that they just look at that first prong, is whether they understand the proceedings. So they know who I am as their defense counsel, they know who the prosecutor is, they know who the judge is, they know what a courtroom is. And they know that they're charged with a crime, and maybe even know what crimes they're charged. However, oftentimes what we see is that they fail the second prong of the test, which is they're unable to reasonably assist their counsel. They don't understand the nature of the proceedings. They don't understand as far as whether they can, as far as waiving jury trial or not, what the possible defenses are, or can rationally communicate with their defense counsel so that they can formulate a defense. And so at this stage, if in fact we contest, at this stage, the parties, just like the initial finding, the initial evaluation on competency, the parties at this stage have two choices. We can stipulate to the findings as to competency, or we can request a second another diagnosis or another evaluation. And then that evaluator will meet with the client or meet with the individual, review both the initial evaluation, review the certificate of competency, and then come back with an opinion. At that stage, prosecutor and defense counsel have those two choices again. Stipulate as to that evaluation or have a hearing. This hearing is not a jury trial though, it's a court hearing. And the burden of proof is on the accused to show that they are incompetent. And they have to prove that by preponderance of the evidence, which is a simple weighing test, is 50 plus. If the person, now next slide. If there is no reasonable likelihood that competency can be restored, then the case is referred to the public guardian for conservatorship investigation. They'll look at LPS conservatorship, and if placed on an LPS conservatorship, the initial placement is usually locked. The other one is a Murphy conservatorship, and this depends generally on the nature of the charged offenses. So if it's a violent offense and the person presently is deemed to be violent, then they will a Murphy conservatorship may be more appropriate, and they will be placed on a locked placement. Or and then the other thing to remember is that the individual is incarcerated in Ventura County Jail until transported to a locked facility. Now, at each one of these stages, as far as if in fact public guardian comes back and recommends an LPS conservatorship or a Murphy conservatorship, the individual has a right to contest that finding and then have a trial as to the conservatorship, just as though they would if they went the 5150 route initially with a 72-hour hold in a psychiatric hospital, and then they can eventually go to jury trial as to the issue of conservatorship. And one thing I want to remind folks, or also advise folks, is that during this process, one is that the public defender's office, when our clients are involved in a lot of these different aspects, we're involved with the placement, we're in continuous communication with the jails, with treatment providers, BCBH, telecare, the hospitals, in order to secure treatment and try to expedite placement into these different both for competency restoration as well as on this side of it, regarding conservatorships. But the other part of it is, this is a reminder, is that we are, as their defense counsel, we are strict advocates. So we work for our clients. And while we welcome the input from families and their caregivers, we work for our clients. And so even though we may think it's best for our clients to be in the hospital, if our clients ask for us to contest these proceedings, we must do so. And so, like I said, we welcome participation and interaction with family, but there's times, unless we have a written authorization, that we can't provide every bit of information that we know about the case. We can provide information that's publicly available, and such as what's in the minute orders or in the dockets when someone goes and looks at the court proceedings online. And then so the other option at this stage is also dismissal of the case. Next. Now, developmental disability pursuant to Penal Code Section 1369(8)(4). They refer to the Tri-Counties Regional Center for Competency Restoration Placement Recommendation. And we primarily see three different placements. One is Porterville Developmental Center, which is inpatient. The other is Sanger Place MHRC, which is also inpatient. And then the third is Psych West, which is community-based restoration, competency restoration. Again, this is competency restoration treatment, not treatment per se. And so there's a difference. The goals are different. And we're talking about treatment, both respecting developmental disability, as well as someone who's experiencing mental illness. In this arena only that I'm talking about competency, is that we're talking about competency restoration treatment as opposed to treatment. So the goals are to prevent the prosecution of someone who's legally incompetent. That's what this entire process is designed for. Whereas treatment in all other aspects is to work on independence and recovery. And so the goals are different, and so the means are different on how we get there. Next slide. If competency has been restored, criminal proceedings resumed. If from the stage where they were suspended, such as arraignment or pretrial, if competency is not restored, the court may order conservatorship pursuant to Welfare and Institution Code 6500, where the individual is placed in an inpatient treatment facility, or the case may be dismissed. Now again, the individuals incarcerated in the Ventura County Jail. And I appreciate the efforts that the Sheriff's Office has done as far as significantly expanding both the nature and scope of the TIMU, the Therapeutic Inmate Unit, and where they're receiving more treatment in jail than they ever have before. However, they're in jail as opposed to a treatment facility. And there were major differences. And as I spoke when I was at the grand opening of the TIMU, I continuously expressed my appreciation for having more treatment available. So folks are languishing less while in custody. And I've had these same conversations with members of the Sheriff's Office. Is that there's only so much we can do with steel doors and cinder block. And this is why it's important that, and I sound like a broken record on this, is that each and every one of you, both here in person, as well as folks who are watching online, is to talk to your elected officials at your city, county, state, and federal levels as far as expanding behavioral health treatment and access to behavioral health treatment. The criminal justice system is not designed to be the stopgap for the gaps in mental health treatment. We see this on a daily basis. On a daily basis, we hear the plight and the pleas from both our clients and loved ones as far as their condition of being locked up in a facility. And the other thing, what I will also want to also emphasize, which I think I've been a broken record on this, is that if in fact your loved one is in crisis and you call 911, please let them know that you're requesting the assistance of CIT trained officers. It's my understanding the sheriff's office has trained every one of their deputies in CIT. However, by making that request, you change the nature of that initial encounter, which can be the difference of someone getting treatment, going to a hospital, and someone living. And so I would implore you to is to do what you can to ensure that folks get treatment at every opportunity that we can. And so if you have any questions, next slide, please ask. Nancy.
I'm not certain, but I think I understand, but if someone is, we've heard that has a felony and then they are determined that they would probably need to have a conservatorship, they still haven't dealt with their criminal offense. And so then if they're going into, say, a locked facility for a period of time, is that a period of time until they become more well and able to participate? And that's evaluated now and then, or how does that?
Okay, so let's look at the felonies. And someone, let's say, is transported to the Department of State hospitals. The hospital needs to provide periodic reports to the court as far as what their progress is and their diagnosis. And oftentimes what we're taking, fortunately, up until I would say about a year and a half, maybe 2 years ago, folks charged with felonies were languishing in jail up to 6 to 9 months before being transported to Department of State hospitals. Department of State hospitals was sued, and pursuant to Schiavetti, that time from placement to transportation has been expedited significantly. And so we're usually looking 30 to 60 days when someone's transported. Or what the other thing that the Department of State Hospitals has done, has funded more jail-based competency training, which is what we have here. 2-3 years ago, that was non-existent in the county of Ventura. There's just maybe a handful of counties that have jail-based competency. And so someone can go, who's charged with a felony, can be in competency restoration treatment for up to 2 years or the max term of their confinement. Most felonies are the sentencing trial, I'm getting into the weeds, but is a max time of 3 years. There's some dispute whether that should be 1.5 years, because they should be given a half time, like everyone else. Or if it's 2 years, but the max that anyone charged with a felony can be in competency restoration is 2 years. Supervisor Leader.
And thanks for this presentation, Michael. That was really interesting. I'm sorry, I apologize. Who makes the determination when you're looking at whether or not competency can be restored? Is a judge looking at these periodic reports from the state hospital or the center, and at what point is it the judge alone makes that decision? How does that process work?
So what the process is that during these progress reports, and they're not called progress, for lack of a better word, I'm calling them progress reports. Those are submitted to the court. If during the periods of these progress reports, the treatment provider, DSH, Department of State Hospitals, or jail-based competency treatment, submits a certificate of competency saying they are competent. At that point, that certificate of competency is filed with the court and then given to both the prosecution and defense. Defense and prosecutor have 2 choices at that point. We can stipulate or agree on those findings as to, let's say they come back and say they're competent. Or we can request another evaluation. And then with that other evaluation, then we come across that kind of like fork in the road again. After the evaluation and it's submitted to the court in both parties, we can either agree on it or go to trial. At this stage, it would be the judge's decision by preponderance of whether the person is incompetent or not.
But then, I guess my question was, that at a certain point with some individuals, there's a decision that competency is not going to be restored. And is it the judge who makes that decision?
Ultimately, it is, but parties can contest it too.
They-
And
okay.
so more often than not, is if there is a, finding that, there's no reasonable likelihood that competency can be restored, both parties stipulate to it, and the judge makes their findings based on our stipulation.
And then one more question, I'm sorry. So once that decision is made, that's when the court refers it to a conservatorship. And so if you have a felony charge, but I guess assuming it's not a violent charge, and the person is not determined to be violent, then they go to the LPS conservatorship, which initially starts in a locked facility. But what's next?
Well, now keep in mind though, we have these like kind of, sometimes they overlap and sometimes they don't. So someone can be incompetent to stand trial, but not gravely disabled. For instance, they may have third-party support and therefore they wouldn't meet the definition, the criteria for gravely disabled. On the flip side, there's sometimes someone is gravely disabled, but they're competent for the purposes of their case. And so oftentimes there's it's like two circles that overlap, but there's times when there's space on either side where they don't line up. And so in both circumstances, they have to meet criteria for the conservatorship in order for conservatorship to be ordered.
Okay, thank you.
Yes.
Thank you for presentation, it's very good. My question is that you say that, for example, somebody is criminal and then they arrest them and then they realize this person needs help. For example, they have schizophrenia and then they attack somebody. So we'll do all these things, like 2 years, 3 years, they get all this treatment. And then what happens? Then when they go back home, for example, there is nobody to monitor them. The same thing happens. So what happens after that?
Well, it depends on what we're talking about. If in fact they're placed on a conservatorship, then it's as if, let's say it's an LPS conservatorship, as if they were in an LPS, it's the same thing as if they were in an LPS conservatorship coming out of from the Hillmont Psychiatric Hospital, where it's renewed every year. So every year it's renewed, just like once a conservatorship ordered, it's just like every other psychiatric conservatorship. And so it's going to depend upon what are the treatment needs of the individual while they're in the conservatorship. And the law says least restrictive placement. So it depends on how acute they are, how responsive they are to treatment. And oftentimes they're trying to get as far as the cocktail of medications. And that oftentimes takes time, and then immunity or tolerances develop as well. So they have to continuously be monitored and adjusted. And so there's a variety of things. Now, if in fact a conservatorship is not ordered and the case is dismissed, then it goes back to as if no criminal case has been handled. And hopefully, what we try to do, but at this stage, we can't compel involuntary treatment. And so we will work with treatment providers to try to get them into appropriate treatment. It could be that we get them at the Crisis Residential Treatment Center, but that's for a limited period. And so we get them there as a transition from the jail to the community. Ideally, if we had more step down facilities, we would be able to do a lot more warm handoffs from the jail to the treatment facility. And then once they're fully stabilized, then another step down to the point where they are stabilized enough to return home.
Yes, thank you, Michael, for that very informative presentation. What if an individual's incompetence is caused by extreme substance misuse? And then is there any intervention for treatment of that situation? And does that render them incompetent after the treatment, or what happens?
If it is solely based on substance abuse, they won't be found to be incompetent to stand trial. So if you look at the first prong, is as a result of a mental disorder, intellectual disability. And that doesn't include substance abuse. Now, substance abuse oftentimes is co-occurring disorders. And so just because someone is using controlled substances doesn't mean they won't be found incompetent if in fact there's another condition present, such as schizophrenia. Because what we often see, particularly people who are unhoused, is that they're self-medicating or there's co-occurring disorders. But they cannot be declared incompetent solely based on substance use. And so, did that answer your question? Okay.
One more quick question. Did I hear you say that clients who, whatever, people can stay in the TMI unit in the county jail for up to 2 years? Did I hear that?
If they are receiving jail-based competency treatment, then yes, I've yet to see up to 2 years. What's the longest you've ever seen, Sergeant?
Some of it just depends on the conservatorship and what facilities we can get them into. Usually that'll take a little bit longer, but if they're in the jail-based competency treatment program, the time there is about 45 days if they can't restore competency. And then they go on to Department of State hospitals. So I can't think of anybody that's really been in there that's been deemed incompetent for a felony case that's been there longer than 2 years.
Any other questions? I see some questions on online as well. Carol Shelton.
Thank you so much. I'm back. My name is Carol Shelton, and I'm representing the Autism Society of Ventura County and our advocacy committee as part of our ongoing efforts to support and advocate for the rights of people with autism. We have been closely monitoring the agendas of Ventura County Behavioral Health Advisory Board and its subcommittees. The presentation titled Incompetent to Stand Trial, the Basics, caught our attention. While we appreciate the initiative to address important legal matters, we are concerned that this presentation marks the first time that we are aware that people with developmental disabilities have been part of a board presentation. One of our core priorities centered around human rights compels us to ensure that people with autism are not only protected, but also receive fair treatment within the legal system. Unfortunately, determining whether an individual may have a developmental disability can be challenging, but it is not impossible. Many autistic people living in Ventura County go undiagnosed and do not receive evidence-based treatment or supports for their autism. This leads to disastrous impacts, which include perpetual crisis, having severely disabling mental health disorders, living in restrictive placements, and involvement within the criminal justice system. We believe it is crucial to address these challenges head-on and implement proactive measures. We urge Ventura County Behavioral Health and Tri-Counties Regional Center to adopt consistent screening to assess policies that are followed by a comprehensive assessment and eligibility determination. We urge the Ventura County Public Defender's Office to screen the accused by conducting thorough interviews with a qualified professional, reviewing educational and mental health histories, and recognizing the barriers to individuals face in obtaining previous formal diagnoses. We are deeply concerned about utilizing the regional center to determine competency to stand trial. Our community has shared that our regional center regularly denies them eligibility assessments, and even when they do agree to assess, they are frequently deemed ineligible despite meeting eligibility parameters. Statistics provided by ARC highlight the alarming rates of individuals with disabilities, including autism, within the criminal justice system. It is imperative to acknowledge and address the systemic issues contributing to the school to prison pipeline for people with developmental disabilities. We believe that by working and advocating together, we can create a more just and supportive environment for individuals with autism and other developmental disabilities. Let's do this together. Thank you for your time.
And I welcome the opportunity to collaborate. The one thing I will add as far as with respect to the Tri-Counties, that statutory pursuit of the penal code. And so by law, the court has to refer to the director of Tri-Counties Regional or to the regional center. Here's Tri-Counties Regional Center or their designee. Elizabeth Stone.
Hi, thanks, Michael, and hi, everybody. I was, I serve as the representative payee for an individual who is uses justice-involved services quite frequently due to her being unhoused and her behavior, or this person's behavior. And was recently in the detox unit where the psychiatrist asked for her to be, this individual to be conserved. And I actually agreed with this given previous medical condition that led to severe cognitive disabilities, as well as the individual telling me that they were now intent on dying by suicide by ingesting certain substances. I did an hour interview with the public guardian's office, and a month and a half later, I was contacted by the public defender's office because the public guardians decided not to go through with pursuing guardianship. And as anyone who knows me, it's pretty severe if I'm going to agree that somebody might need to have other people involved in making decisions about them. And they were asking me to become this person's conservator, with the idea that they could then ask the public guardian to take it over. When I called the public guardian's office, which is now under VCBH for whatever political reasons, I was told that de facto, if a person is unhoused, they refuse to do any guardianship, any conservatorship. And but what if part of the reason the person is unable to maintain housing is related to this and they need the support? So it's very concerning to me that rather than kind of person-centered, individually based deciding this, that there's this uniform decision that people that are unhoused or currently are experiencing homelessness are not going to be able to perhaps get the services that might keep them alive. So as we see, again, as the intersection of housing and public health and behavioral health concerns are all merging, and within the next year and a half, these budgets will be very intertwined, as well as the data and policy decisions focused largely on people meeting these characteristics in their lives. It's very concerning to me that the public defender's office didn't even know that the public guardians are now discarding this entire group of people. So I know this is somewhat tangential, but you did mention, conservatorships and guardianships. So I would really, again, like to make this board of individuals who have decided to spend their time concerned about this issue aware, number one, of the silos, so that within the county departments aren't communicating, and they may actually not be working in concert for the best interests of the people that we're trying to improve their quality of lives. So thank you for letting me share that. Of course, I'm open to hearing any feedback on that as well.
Respond real briefly as one that we frequently communicate with everyone involved with the process, and we have often had, there's been guardianships, LPS and Murphy, LPS conservatorships and Murphy conservatorships of folks who are clients of ours who are unhoused. So I don't know where that information came from, but I know we have frequently, many of our LPS clients that we represent were unhoused prior to the initiation of the conservatorship process. Any other public comments? Or comments from the board? I'm not seeing any. I see Elizabeth Stone real briefly, please.
This was told to me 2 weeks ago after the department was put under VCBH. And I can give you the individual's name, and the sentencing specialist in your office are the people that are asking me to do this, so.
Thank you, Elizabeth.
It could be a change, and since care court's not going into effect, maybe I don't know what's going on, but it's really concerning.
All right, thank you. Any other public comments? All right, moving on to item 9, chair announcements. I don't believe, I didn't receive, I double checked my emails, and if James or Jackie I'm welcome the correction, but I didn't receive any reports from Janice Gardner for today, so based on that, I'm gonna ask that item 9 be tabled to next meeting, and then move on to item 10, director's report. Dr. Loretta Dinnery, interim director.
Thank you, Michael. In your packets, you have a fairly robust director's report this month. Focusing on, I want to call your attention today on a couple of infographics and some graphics that we've included. Given that there's a lot of information coming out at the state about Colleen and kind of where we're at as a state. One of the documents we have is an infographic on the Colleen Behavioral Health Quality Improvement Plan program that we've been involved in since September 2022. This 2-page infographic gives you kind of a timeline on the various goals and metrics that we were required to meet. This was a voluntary program that county behavioral health agencies had the option to opt into. And the whole focus was to help in the transition with Colleen to improve administrative reforms, given that there were so many changes handed down all at the same time. So feel free to go through that, and it has our goals, the milestones, and then the incentive funds at the bottom that were achieved in each time period. Our entire quality improvement program report is also included. That gives you more details around, some of the activities that were involved. And then related to that is information the Department of Healthcare Services put out just last month in February that was referenced earlier as far as county behavioral health plans and our ratings. So as many of you know, the transition into Colleen really moves county behavioral health into a managed care structure. And much like managed care plans, our Medi-Cal managed care plans in our county, Gold Coast Health Plans, our Medi-Cal managed care plan. There are a number of quality metrics that we are, measured on. And so for the first time this year, the state released measures for both the specialty mental health plan and the DMC ODS plan. And you see where we lie in comparison to other counties across various measures. So these data are from measurement year 2022, which was the first year Colleen behavioral health kicked in. And so moving forward, we will get updated numbers that, will be in retrospect a year or two, depending on how quickly the state is able to put them out. And we anticipate these measures will change over time. So these first reports were really like the baseline years. And so you can see where we fall in comparison to other counties across the state. So feel free to reach out with any questions there. We've also included our active client consumer data that we had been providing regularly with the transition into smart care. We had to suspend that until we were able to get those reports together, but now they are back. So you will see the monthly consumers included in this report moving forward. And the last thing I wanted to talk about before I take any questions is just to update you on some state level work related to Colleen behavioral health. Just last Thursday on March 14th, the Senate Health Committee and Senate Budget and Fiscal Review Subcommittees number 3 held a joint oversight meeting to discuss the components of Colleen. with the Department of Healthcare Services and various stakeholders, including California Behavioral Health Directors Association, California Council of Community Behavioral Health, California Alliance of Child and Family Services, and California Pan-Ethnic Health Network. And this committee was led by Senators Roth, Eggman, Menjivar, and Rubio. And what they talked about was a really robust conversation, and we can send out, the Senate website has the agenda, the background paper, and DHCS's County Behavioral Health Report posted, which we can circulate after this meeting. But it was a really interesting panel because it talked about the statewide impacts of CalAIM across the board on the department. So the Department of Healthcare Services at the county level, and then also at the community behavioral health provider level. And some of the highlights included the challenges that were implementing CalAIM right coming out of the pandemic, with the workforce challenges and an increased demand on behavioral health services, which we all are very familiar with. Another piece that was critical was the discussion around the volume of new initiatives coming online for county behavioral health outside of CalAIM, and the ability for counties, especially smaller counties, but even larger and medium-sized counties, to manage the administrative tasks faced with all of these mandates coming out simultaneously. Another huge piece of discussion were the ongoing challenges regarding the rates and the coding changes that came with CalAIM payment reform. Counties received the rates just a couple of months ahead of the July 1st transition last year, which made it very difficult to negotiate rates with providers. The discussion also centered around the limitations with modeling and negotiating rates. And so counties had to take various approaches based on the information that they had at the time, and the Department of Healthcare Services inability to provide timely technical assistance related to the rate rollouts last year. There were also changes to the electronic health record, which complicated coding and billing. And so that has, made it where the department, the state level has, maintained, well, we know it's going to take at least a year for everyone to kind of settle into this new world. But, people have needs at the moment now. So it's like, how do we meet the needs knowing that things will get better in time? Another piece that sometimes gets missed is there were also transition tools and updates to screening tools that came out under CalAIM. And so what it's done is we've seen across the state where several children and youth are identified as needing behavioral health services that are actually more appropriately served by the commercial plans. So folks with mild to moderate. And what we're seeing is because there are insufficient networks on the commercial side and on the medical managed care side, a lot of these referrals are being inappropriately sent to county behavioral health, which is increasing the burden across our specialty system. So that was a part of the discussion, as well as other administrative pieces related to payment reform, including nuances that, we feel as a provider ourselves, with changes due to CPT codes, which we've talked about, the fact that travel time is no longer included. And so how do you balance that? And so just a lot of kind of in the weeds conversation. So I encourage you to take a look at the report out from the Senate hearing. It was a very robust conversation, including some of the concerns that we have in county behavioral health, but also, and our community-based providers about, some of the initiatives, while well-intended, there are consequences to some of our other, racial and ethnic groups where they are seeing an increase in not being able to access services because of some of the policy changes. The county changes were not necessarily about racial and health equity. And so some of the policy changes are making it difficult for people who already have challenges accessing, especially when you're talking about language and culturally appropriate services. So working through that, even though, you have your administrative requirements and then trying to meet cultural needs at the same time and finding a place in the middle. And so that's some of the work that we hope the state will engage with because we see it at the ground level, obviously at the county level, and our providers do as well. And so those are some of the pieces that we've brought to their attention. While well-intended, some of these administrative and policy changes, they're having a negative effect on some of our other providers or other populations that we serve. And the last piece was really, again, about talking about the larger concerns, behavioral health, the lowercase b, and the intersection between the specialty system and the Medi-Cal managed care system. And there was just lots of statistics thrown out, but one was pretty striking. In 2022, fewer than 4% of Medi-Cal members had continuous engagement on the managed care side, highlighting that access for patients in Medi-Cal managed care plans is worse for patients accessing county behavioral health services. So because our insufficient networks within the Medi-Cal managed care world and the commercial insurance, a lot of folks are coming to county. And so it makes it challenging to serve various populations that we don't necessarily have the resources for because we don't want to turn anyone away. We are, the state has acknowledged that it's going to take years to fully implement county behavioral health and that, everything we're doing right now are point in time snapshots, but a part of, the bigger picture. And it's just going to take time. And then obviously, the still big unknown are, the implications of Prop 1 should it pass. There's a lot of intersection between Prop 1 and Cal-Lane. And so it will, to be determined as to what that looks like moving forward. But we are, working very closely with the state and the associations to plan for, the changes when they roll out. So that's it today. Any questions?
Thank you. I appreciated the thoroughness of your report. It really was, really good to read. Thank you.
Thank you.
And I can imagine your department goes through all these changes. It seems like a lot of times this happens, and just the inefficiency of all that is kind of mind blowing when you're just trying to serve clients. But regardless, anyway. I had a question on page 5, the strategy planning and administrative services under that. So it looks like, I didn't quite understand this. Is the staff officially transitioning to this, is that a new division, strategy planning and administrative services team, or can you explain?
Oh,
that
sure.
a little more?
Yeah, so it's not new anymore. So it's an office that we created actually February of last year, February of 2023. Because of all of these new initiatives that were coming down, we historically were not set up to handle, tracking policy and planning out, and then service delivery, and then everything in between. So one of the strategies was to create this planning, we call it SPA, strategy, planning, and administration. So our strategic initiatives are there, our strategic planning, and then your regular administrative services like contracts and all that, really to focus and give a central point to the initiatives in the preparation and planning stage. So one of the examples is our CARE Act preparation. So we have some information in the report as far as all our activities. So our SPA team handles kind of coordinating all of the efforts around CARE Court implementation right now. Overseeing the work groups, working with the various departments, the public defender, the sheriff's office, whoever's involved as far as, managing all the tasks, working directly with the state, working with other stakeholders to hold the information and then disseminate it out as it needs to appropriately within the department and then within the county. Because that is a full-time job in and of itself. So that's why we have a team now to assist our clinical operations, to assist our quality, to assist our admin folks, to be able to maintain and hold so that we can stay on track with all of the things that we need to be doing.
So is the team made up of how did you populate it?
So we took what was our CalAIM team. So we created our CalAIM team in the fall of 2021 because we knew CalAIM Behavioral Health was gonna start early 2022. And so we basically last year transformed that so that they could do more than just CalAIM work, because we have CARE Act coming on, we now have MHSA reform coming on, SB 43. So we have all these different initiatives. And so we expanded their role beyond just CalAIM implementation. Also, as pieces of CalAIM became more implementation and operational, they fell to like our quality care, managed care services department, or clinical operations. And so there wasn't so much policy related work anymore. So they could shift those things and then focus on these new initiatives that require policy development and analysis.
Okay, so, okay, so it's sort of already been there, it has in many ways, but are you expanding it or just, this is just kind of reporting on?
So, we've been reporting on this, I think, for a year now, but it really was just pulling together the folks who were doing that work and giving them the kind of structure and the overheads to just be like, this is your group and this is what you do, and this is separate from the folks in the day-to-day.
Okay, yeah, okay, great, thanks.
If I can follow up, what you're referring to right now is the internal committee with respect to CARE Act, not as far as the broader stakeholder meetings that are in place with the courts, public defender, probation, and other providers. Is that correct?
Correct. So there's actually 3 levels currently. So there's the internal working group, folks, boots on the ground planning. There's kind of the management level, really looking at all of the implications across the board. And I'm talking specifically for CARE Act. And then there's the executive level. So the folks, you know, public defender, county council, myself, healthcare agency, like sitting at that level. And then what will be coming, and we've been working with our consultants at HMA who came down last week to do that kickoff meeting with our working group folks. What will be coming is the public stakeholder information. You know, once we are ready to get the messaging and the communication across the county, because this is a partnership program. No one department owns CARE Act. It really is all the hands together. Once we're in that place, then there will be external communications. We will invite, you know, external stakeholders to sit and listen to, you know, based on the cohort 1 county experiences, what our plans are for Ventura County, and then elicit feedback there.
Okay, so on that committee that you're just talking about, you say there's no one organization, I guess, in charge, is that what you're saying? It's just kind of, I mean, because somebody has to be in charge of
So,
something.
Yeah, no, I'd say the lead is behavioral health, but care court is a core program. So it's a core program with a huge behavioral health component.
Right.
Right. So what I'm saying is all the players are at the table, so everyone's involved in the planning. It's not behavioral health saying this is what we're gonna do, and then, you know, because it's a core program. So obviously they have their say in how things are gonna go.
Right.
And then obviously we welcome the input from the public defender, you know, sheriff's office and other stakeholders who, you know, will have some role in CARE Act.
Yeah, okay, thank you.
Thank you, Dr. Dennery. Just a question for the measurement year for quality scores, is it the same as this last year reported? And is it 4 quality score measures or 11 that you're currently monitoring?
So for 2023,
Yes.
yeah, it will be the same.
Okay. So is it the same 4 here highlighted in the county summary, or is it 11 as a summary here in the second page?
So we report out on the 11 and whether the state chooses to, you know, publish that. They've selected these 4.
Okay, so it's the same 4 published
Yes.
as for 23.
Yeah.
Thank you.
Yeah.
So,
Hi, you were totally garbled. All right, so I have a couple of questions. This says that you're starting toxicology screening in the short-term treatment teams, and I'm curious how that works, because I was very excited about that project because it seemed that people could get sort of get support in what they need without fear of being labeled. But now it seems like you're doing drug testing on them. So that's one. Should I do like one question at a time? That's one question I have. Or should I just put out all the questions I have?
I can respond, I mean, so in the spirit of integration, obviously, which is the focal point of CalAIM, one of the pieces is clinical integration. Obviously, we know we have a lot of clients who have co-occurring disorders, but they may only present in one area. They may only present in mental health clinic, or they may only present in a substance use clinic. And so what we are doing is meeting the needs that have been, there for quite some time and have been, staff and have been vocal at meeting the tools to address substance use in primary mental health settings. And so this will be one of those tools where we're doing much like a universal screening when folks come in, starting to change the language and the narrative and the perception of getting tests just upon screening like you would anywhere else. Especially when we have the resources that they would need if they need substance use treatment or even early intervention services, and without them having to ask for it, and just building that in as part of their regular care.
Is that something they can opt into, or is it mandatory to allow someone to do that in order to get services?
No, so folks can decline in either setting and still receive services, but it's
Okay.
not going to be something they have to ask for.
Yeah, that's just what I wanted to make sure that it was voluntary. What does ILT stand for? It's on the top of the second page under Youth and Family Division Leadership.
Oh, the interagency leadership.
Inter what?
Interagency leadership team.
Okay, great. Thank you. I was wondering, in terms of the contingency management program, it just really struck me that there was a comment that some people are opting to wait for their contingency reward toward the end of their services instead of each clean drug test. And I'm wondering if you're seeing if there's any difference in terms of outcomes with the people that are waiting versus the people that want the immediate results.
I can't. Okay, no, so. Yeah, so this is new, but so far we have not seen any difference. And UCLA is doing a formal outcome study, and so we will be a part of that with our information.
It just seemed like such an interesting way to have like a control group, so I thought it would be interesting. I have a comment on the collaborative documentation. I'm really excited to see that that's something that staff is getting trained in. That was something I was trained in 2007, and about 7 or 8 years ago had been urging John to ask staff to do. So really glad to hear that. There's a comment in here that there's thousands of people that are unhoused in VCBH, receiving services from VCBH. And I'm wondering like what the actual numbers are, because John keeps saying that there's no record of people being unhoused or the data. And in terms of your 4 pages of the kind of characteristics of people that are being served, I encourage you in that to include data on who is, just numbers, obviously not who, but in terms of the in addition to these demographic numbers, I encourage you to provide data on the type of housing and if people are unhoused. And also, I think it would be helpful to take a look at the kind of diagnostic groups of people that are receiving services, because I know that frequently there's conversations as though, especially when looking at the need for, quote, treatment beds, which people usually mean locked inpatient, people are thinking everybody has psychosis-related symptoms, when in fact, generally 50% of people in a hospital ward are there because they're thinking of killing themselves by suicide. So I think it would be, I believe it would be helpful to also have that kind of data about what the issues people are bringing forward when they present for services. But is there an actual number instead of the many thousands of people that are unhoused?
I'm not sure where you're referencing, but I'm sure we can find a number.
I will tell you immediately. It's on page 6, top paragraph, under overview of major changes, talking about housing and the bond funding. Thousands of county behavioral health clients are currently actively receiving treatment despite not having permanent housing or shelter.
Page 6. Okay.
And I appreciate the I mean, I value and share the aspirational things in the subsequent paragraphs about housing. I'm just wondering where, because we know the biggest problem is there isn't sufficient housing. So,
Okay, so this isn't Ventura County specific. This piece is actually highlighting the overview of BHSA. So these are the high level overview of the changes that will happen. We were asked to provide a synopsis of should Prop 1 pass, what sort of changes would happen. And so this is part of the summary of changes. So the thousands refers to thousands across the state, not thousands in Ventura County.
so this is a cut and paste little section. This is really actually not about us.
So we were asked to give an overview of the statewide perspective as far as changes that we anticipate to happen. And so that's what this is. This is a statewide perspective.
So I would like to encourage you to be specific when you're trying to provide. Yeah, it would be good just to have accurate details and be specific. And again, you know, I know the county's received a lot of money from the CARE Act already, and I have never heard a report out on where that's gone. There's a lot of things going on where we're not really hearing, and there's a lot of busyness in this report, and there's zero outcomes. So again, I really encourage, and that's part of Prop 1, if you listen to DHC, the Department of Healthcare Services leadership, is actually getting data on outcomes. So I see a lot of kind of busy action, but I'm not really sure how people's lives are changing and how we're, impacting people living with distressing behaviors and thoughts.
Moving on to item 11, we have committee reports. Transitional age UK. Elizabeth's not here. Do you have a report, Elizabeth, on the take committee? And it's list you as former chair.
Sure, yeah. So first, since it already says on their former, I resigned as chair of that committee. It's become apparent to me that a lot of decisions are being made at a black box, that they check a box, they've taken input and whatever. So I'm just not going to spend my time taking that responsibility. So I made that announcement that I've resigned as chair from that committee. And we actually had Nancy, I think that's is been very generous in sharing a lot about what's going on in her division and the programs that she's running. So we had a really great discussion and question and answer on that. And she also, and I was very grateful and thankful that she brought the new director of peer services, who of course I've been interested in meeting. And we had a very long, probably about 20, 30 minutes of our time was also spent listening to him, and he and I and some others having a conversation about what he's hoping to accomplish. And I was really glad to hear that he's familiar with a lot of the people that I've worked with across the country and know the work that they're doing. He states he's also interested in seeing peers in the emergency room, which we're looking at the PIPs again, follow-up appointments. It's an evidence-based practice. It's a really good investment. The county receives money to have somebody in the emergency department when people show up in overdoses or suicide. Why don't we have a peer there? Peers can be doing a lot of this work. Peer respites, unlocked facilities that are alternatives for people in crisis, getting trained support from trained peer supporters. So that was kind of the I think the most important things that kind of happened in our thing. CJ, if you want to add anything. There is also a question about participation in some of the MHSA hearings. And it seems like I know there's an individual, because I've heard from a number of sources, who does quite a lot of work engaging the members of the community that she shares in participating. And so there was a very robust attendance in Santa Paula. And apparently there is a sense from other locations that they're not sure, that there's less participation. Again, with maybe questions about, is this the best investment of my time? Are things actually going to reflect the input that various community members are giving? So that was my last meeting as chair. We have always had a quorum in that committee, so I really respect and thank every committee member. And that's it. Thank you.
Thank you, Elizabeth. Moving on to B, adult services. We did not receive a report from Chris Tejeda, who was unable to be here today, so we'll table that to next month's meeting. Moving on to C, disparities reduction, Torres.
So I just
And
want
Jennifer.
to start and then I'll hand it over to Genevieve. So we have not been able to meet for several meetings now because we don't have quorum. So I just urge fellow BHAB members who are part of the committee to please join us. And then in addition to that, we're going to be really doubling our efforts of increasing participation from community stakeholders, so that we are able to establish quorum and begin to have these meetings. So our next meeting is in May. If you're a member, we'll also be reaching out to you individually, but really urge you to please join us so that we can begin this important work. And then I'll hand it over to my co-chair. Nothing? Okay, thank you.
Do you know when the next meeting is, by chance?
Jackie, is it? Second week or first?
It's May 7th.
May 7th at 4:30.
Moving on. Moving on to item 12, for comments and announcements. James Espinosa.
All right, thank you. It's been a hearty discussion here today. Thank you, Mr. Rodriguez, for your presentation, and for yours as well. A couple things, just for BHAB, I've been invited to the State Board of Equalization meeting that tomorrow. They have a bunch of questions regarding Prop 1 implementation and how taxes may be affected in terms of building in brick and mortar. I don't know if you want to have someone there that might be able to chime in to see how it might impact the county, but they specifically asked me. They have kind of as you talk about getting into the weeds, they have questions regarding getting into the weeds about what's going to be built, what's not. They can do tax exemptions, things like that. So it might be interesting to have someone attend, not in terms of how your knowledge of the implementation, but how it might be best served for you.
Yeah, unfortunately, we don't have that information,
Right.
so we're still waiting for the state to give us that.
As am I. But just offering that up,
Yeah.
to see what type of question you have,
Absolutely.
and how you might implement it. Second thing, so I noticed that there is a veteran section here growing with resources. If you at the back of your report, I believe that's part of the director's report back here. I appreciate the knowledge and the VA information. I just want to also note that the VA, for a lot of veterans, unfortunately, still in us culture, is a trigger for a lot of veterans, and they're averse to wanting VA resources because of the delays and problems they've had in the past. So that's why there's 43,000 plus veteran nonprofits supporting veterans. I love the VA and what they do for our veterans, but they have a very specific role. May I ask and add that I'd be happy to offer up vetted resources that are non-VA, that are culturally competent. That may be helpful as well, being that this is a public report. Even for me, I immediately see all of these articles from the VA and I kind of get a little, for lack of a better term, just irritated, only because that, not because of the effort, and that's a lack of a better term, that I know the history, and I know that it's helpful to have also vetted non-VA resources, and that's mainly why. And nothing to the effort of whoever put this listing.
No, absolutely, we would welcome that, so thank you.
Thank you, and sorry, I have one more thing. We are still planning the Military Appreciation Month event in Camarillo on May 18th. That's going to be for veterans and first responders. We are still in the planning phases, but I believe the park has been reserved, which we will get more information on. We're looking for culturally competent veteran and or first responder resources that may want to attend as a resource booth. And also looking for people who may want to donate to help contribute to the cause and maybe even be a sponsor of the event. That's on May 18th, 2024, tentatively at Constitution Park in Camarillo. And I was wondering if BCBH has any funding available that they may be both able to offer up or sponsor the event, if that is even a possibility. I just wanted to ask in our planning phase if that's a possibility, if there's any additional funding available. That's about it.
Thank you, James. Any other board comments? Not seeing any. Moving on to item 15, update the impact of CalAIM and perform on community mental health in Ventura County. Eric Sternard, Sternard, right?
Yeah, that's fine.
Okay, sorry about that. Ventura County Providers Network, ECPN.
Great, thank you, Mr. Rodriguez, and board. Appreciate the opportunity to come and speak to the board from the perspective of your community-based providers. My name is Eric Sternad. I'm the Executive Director at Interface Children and Family Services. But today my hat is as the chair of the recently formed Ventura County Community Providers Network. And I'm joined by Melissa Hanna, who is the Executive Director of Parents United, United Parents, who is co-chair of the Community Providers Network. So next slide, please. What you'll see is just the kind of the goal of this providers network that we have in our charter, which we formed, a network committed to lifting up the community-based providers, fostering communication amongst us, with our county and healthcare partners, and cooperating with all for the good of the community. So I think we very much want to work in line with the goals of BHAB here, the department, and all of us as fellow providers trying to meet the many needs in the community. Next slide, please. So here are the original charter members. So the 6 organizations have and their respective executives have got together to form this community providers network. And we just recently brought on the Coalition for Family Harmony as well, and we are intending to continue to add other providers that are basically in the mental health arena, the child welfare arena, and probation arenas. So that's kind of how we sort of see the ultimate scope. Next slide, please. So what we're really seeing as opportunities for the network to work on better system coordination, to be able to have a more proactive, I think, feedback to children and family systems of care, policy and practice improvements. So we very much want to be a partner at the table, helping to kind of shape the developments of system improvements. Totally appreciate Dr. Dannering's report and the fact that you're kind of being inundated with quote unquote opportunities for improvement these days. So we fully appreciate how challenging that is. But we feel like, you've got decades and decades of experience across all the providers. And hopefully, with some good, maybe increased collaboration, we can hopefully head off some wrong starts or be able to anticipate things that we might help some of these system improvement initiatives to go easier for all. And again, I think we're all experiencing a challenge as it relates to the access to mental health staff. There's a huge mismatch, as we all know, in terms of need versus available staff. And we think there may be some efficiencies that could be deployed in partnership. We hope to be a part of that discussion. Next slide, please. So the areas of concern, I think that led to this desire to come and speak to you today, came out of some of the public comments from your last meeting, if you remember. And really, overall, again, what you'll hear reflected here, definitely mirroring some of the comments that you've already heard from Dr. Dennering in terms of the feedback happening across the state about CalAIM reform and payment reform, or the CalAIM changes in payment reform. Our sense is that on the whole, this fiscal year has definitely weakened your CBOs, your community-based organizations providing the community-based mental health services financially. The revenue opportunities that we have with the changes are restricted. That's not just the problem, it's really that they aren't covering costs. And so I think what we're hearing from some of our members as we've had some of these discussions over the last several months is that folks are talking about the risks of being able to stay in business, being able to continue to do this work, which is really alarming. Many of us, if not all of us, have been providing community-based mental health services for years and years, if not decades. So to be able to be at this point where we're looking at each other and saying, hey, well, I'm not sure if we're actually gonna be able to continue this or not, is just is an important thing to communicate. It's just kind of the level of concern. I think that's happening amongst the providers at this point. We know that the transition to smart care has been challenging. I've been part of a number of transitions to new technologies. None of them go smoothly. None of them go like the vendors want to tell you how easy and awesome it's going to be. But it really has been a major factor for the implementation of our contracts this year, having to do a lot of training, some of the systems not really being ready and even reporting not fully ready yet, even though we're deep into the first year. And this has been part of the challenge for the providers, not being able to kind of visibly see how we're doing so that we can make, kind of mid-course corrections as we should. And that's just been a feature of the challenges. Next slide, please. We very much appreciate the recent incentive payment structure that was created by the department. And we think that's going to be helpful to help us recover some of the loss in revenue. But the way it was structured, to be frank about it, also created more administrative challenges, more, reviewing and kind of, generation of content to be able to apply for that. We get the fact that we need to be accountable for the dollars that are being put out to providers, but just to tell you that it's sort of we've got stress systems already, and then the additional demands sort of have added on to that, which has been kind of a challenge that folks have been talking about. And I think it may just be, and I think this is probably going to be the next set of conversations I think we'll be having, is really just to look at the rates themselves. We all were rushed by the state to be able to try to put a rate structure in place for the contracts for this year. And they may just be insufficient for meeting costs, for your provider network, in the community at this point. So, I think that's something we'll probably be having more conversation with the department about. The current and long-range competition for mental health clinicians, this is gonna persist for years. Looking at a recent federal projection of looking at the mismatch between demand for mental health services and the supply of available clinicians between 2020 and 2036, was the data I was looking at. A 60% increase in demand versus a no more than a 6% increase in available clinicians. So you can see that there's over a 50% mismatch in terms of increase in demand versus the available clinicians to do that. I think this is a call for us, all of us together, to really look at how right now, everybody's kind of fighting with each other for talent, and we're paying more and more to try to achieve that. Clearly what we need to do is grow the pie bigger of available clinicians that we have to do this work. And so maybe there's some ways for us to, and that's in the next slide, if you don't mind, is one of the recommendations we'd like to make is really to engage in some joint review at a high level about staffing across our entire system and looking at how we can deploy the most cost-effective ways for us to be able to get folks in front of our community members who are needing mental health care. And that also includes looking at peer support and how that's deployed in our county. We may not have magic answers, but we definitely want to be part of that conversation. And we do think we have some ideas that we'd like to explore together. And hopefully that can be the plan, again, to increase the overall workforce. Because again, if we're looking at in the next 12 years or so, a 50% mismatch in terms of the number of clinicians and the demand that is being predicted, we're gonna need to do some things differently. And then last slide, and then happy to answer any questions, have some conversation. We really look forward to be full partners in looking at these emerging system transformations. I haven't heard a single provider say that they are unhappy about CalAIM or the aims behind these initiatives and the changes. It's not that you've got folks who just want to do things the way they were last year. That's not at all the spirit from the providers. It's just having enough tools to be able to do it and to do it successfully is, I think, where we're coming from. We again think it's really going to be important to work together to find ways to make providers financially whole this year. The last thing I think we want as a system is to see providers wipe out and then have even less capacity to meet community need, or to limp into next year carrying big kind of negative balances and making folks really struggle to try to make ends meet. That would not be a system that's going to be improving, as I think we all want it to be. We also think it's really important to be setting some aggressive timeline about when smart care is going to be able to be accurate and meet the needs that providers have to access key reports. Again, that's part of what we need to be able to see the data that is coming out about real-time use, so that we can make some better and quicker decisions. And hopefully turn things around from our side and perform in the way that we all want to be performing. And again, we want to promote better person-centered care and other ways to serve the community at large. We've got some providers that are really providing evidence-based practice, best practice work. And we want to just try to promote that and secure that for our community as best we can. So really appreciate the opportunity to present, and happy to answer any questions, comments that board members may have. Yes.
Thank you very much for the presentation, Erin. Just a comment. I've heard from, I'm an LCSW, and I've heard from several younger LCSWs who are from mothers, for example, who be fathers, and they look for part-time work because they have children, or they look for more flexible schedules. Is that something, and a lot of people, a lot of agencies seem to be just hiring full-time. So is that something you all are looking at or would consider?
Yeah, definitely. I think there's probably a range there of openings and possibilities across the providers. Whenever you're bringing on more part-time, workers versus full-time, then the overall efficiency of your training and your QA work and all that also goes down. It makes it a little bit more administratively difficult. But these are the kinds of ideas that we should be kicking around and figuring out, because I think we're gonna need to pull multiple levers in order to be able to blunt that mismatch in demand versus the supply of therapists. So that's a great idea.
And just one other question, what opportunities do residents of Ventura County have to get training? And I know that the social work from Long Beach used to do a training here on a 2-year program here. I don't know if they still do. But what are the universities and local colleges doing?
Well, again, I think that needs to be part of that conversation. It takes, it takes at least 2 years from someone has a bachelor's to more likely 3 to get through a master's program and then be able to be at that sort of initial stage of getting an intern license and being able to be sort of included into the workforce to really kind of get at what we're talking about here. So I think engaging the educational institutions in that. We're having some conversations internally about how can we promote future therapists of color to be able to come in and meet the needs of the clients here. The research is very clear that when you have those kind of matches between clinician, practitioner, and their clients, the outcomes are better. The experience is better for the consumers. So I think there are ways to do it. We just, it's gonna take all of us working together, to do it, however.
Thank you for your presentation very much.
Yes.
All these presentations today have been wonderful. We really appreciate everyone's effort. Having said that, on one of the things that you talk about, you say revenue opportunities are restricted and there are covering costs. Are they restricted from how they used to be, or
Right.
so in what ways right that?
Yeah, they're just a different, there's 2 factors there. There's just a different set of rules about how to actually draw the revenue down. But then one simple example would be that before, we could pay for transportation, for time spent, traveling from one site to another. Now that's not permitted as a billing opportunity. So it's really a combination of both. There is a restriction, and that's fine. It has to be just reflected in what that overall rate is for it to be really to cover the cost. But it's also, and Dr. Jenner talked about this as well, the pace of change and getting clinicians to really understand that and fold that into their new practice. When they don't, then the agency, mine and other providers, they can't bill for services. So we're losing money. We're spending the money in employing that clinician. But if there isn't sufficient billing, well, then we can't earn the revenue, and then that's when we get in trouble.
I just wondered if it was new to what's going on now. Well, that's one thing, certainly transportation, but if it's actually, I mean, that's caregiving, it's getting from one spot to the other, it takes time from the clinicians. But are there other factors that are, like, certain kinds of care are okay and certain kinds are not?
Yeah, that's true also. I would say, just speaking for my shop, we're seeing the clinicians get it and understand it and make the changes. It's March, right? It's not July. So we've gone through the better part of the year of this big learning process. And so that's part of what's really stressed the community providers, is the amount of time it's taken to do training, get folks up to speed. They're sort of taken off of their jobs, for that training time. So it's not that they're not getting it, they are, and we think that next year should be smoother unless we have a whole raft of new changes. Let's hope that doesn't happen. But assuming that the pace of change has slowed, we think we'll get there. It's just how do we deal with this year, given that our productivity has been so difficult to find because of the amount of changes. So again, we appreciate the incentive program. I think for a number of the providers, that's not really sufficient, but it was helpful for sure.
Elizabeth Stone.
Thank you. A lot of what you're saying pretty much concerns me, but probably in the opposite way that you're hoping. I'll just say that up front. And my opinion on this, or my perspective, is informed by comments that were shared to the board about the low productivity levels, and that how that contracts that the majority of CBOs currently receive were higher than what the state actually had intended. And also sitting in numerous state meetings, discussing a lot of this, the funding. And, well, I'm going to share the other thing. So, basically, the providers have gone from a blank check to spend however to having to bill for services. And so when we hear that the productivity is very low and the state is really is making this transformation of, instead of kind of like block grant, big grants, of billing for services and shifting funding to bill Medi-Cal, that is like a very big difference. And it is incumbent on agency leadership to ensure that their staff are billing and understand how to do that documentation. And I know that, and having been on that side of things, I know that that can be really tedious and frustrating when people would prefer to spend time providing services. And I've heard from your co-chair how much time is also being lost to having to sit through these numerous trainings every year on like sexual harassment and all these things that are just like watching a video zip by. One of my questions though also is, as the state is emphasizing kind of moving toward more non-traditional, non-clinical, non-corporate services, that having community-based organizations or CBOs to have to bill Medi-Cal can be pretty onerous just because of the infrastructure and security necessary to be able to do the billing, giving HIPAA and all that stuff. So I'm kind of curious. I'm confused by your statement that you don't know how you're doing. I guess something related to smart care. So that part I don't understand, how you don't know how you're doing. But, also looking at the jobs, I'm not sure why you only consider your providers clinicians when there's so many positions that don't require a degree that are paying minimum wage. And those seem to be having a lot of direct care provision. So there's a lot of questions I have, and I know that in general, I support a lot of the changes that the state's making. And it really means that people need to think about doing things differently. So I just really, encourage you to be shifting some of your mindset as well about that. And, Melissa and I have had, probably she doesn't want to get called out, but, we've had some conversations about this, but, across the state, CBOs are having difficulty billing directly again. And I was kind of hoping initially, oh, well, maybe this is where there's going to be this hub for like sharing these billing costs and things, but it's more like what I kind of hear you saying is, if you don't give us more money, we're going to close shop. And, mm, I don't know, that kind of rubs me the wrong way kind of thing. So, and again, I'm not as familiar with the children and family systems as I am with adult services. So, I just, encourage you to maybe address some of the concerns that I'm raising, because I know the state has also said that in terms of residential care, and I'm not really sure how much Interface does, but I know Casa Pacifica does, that when they set those daily rates, they assume certain services were being provided, which in fact they weren't. And therefore, they made additional billing possibilities because they want to actually measure that supportive services are being provided, not just kind of custodial care in residential settings. So I really encourage you to look at the state level of how much the state is kind of mandating that the counties are allowed to pay, because Scott said he went over that doing the contracts with you guys, and what these new billing opportunities that the state DHCS has put into place so that providers can document and prove to them and therefore get enhanced rates for actually providing supportive services as well. So thank you for listening to my comments.
Sure, and I'm happy to follow up with you, offline as well, that would be helpful. I mean, I guess a couple of quick comments and then I'll turn it back to other questions, but, there's never been any blank check as it relates to Medi-Cal services. It's always been doing it for 20 years, always, highly regulated, many things you have to, qualify for in order to draw the funds down. So it's really just that these are different, new, they are, a little bit more restricted this year. And it's really just the timing of having providers being able to have enough time to get their staff trained and be able to do efficiently. I think I'd speak for all the providers. Everyone is wanting to be able to serve their community. This is why providers are doing the business they're doing. And I think we're just, I guess we just feel like we need to inform the board of the status of the providers. And I think that was kind of the main objective here. So I'll leave it at that and see if there are any other questions, comments.
Thank you, Eric. You're welcome. So moving on to item 14, new business. I'm gonna lump these together, A, presentation requests and recognition award recommendations. I would encourage you, if you have any presentation requests or recognition award recommendations, to contact Janice Gardner as well as Jackie at BHAB admin at ventura.org. And I don't know what that schedule is right now, but I believe next month is also scheduled with book. So please get those recommendations or requests in, and including description of the presentation and who, and as well with respect to recognition awards, provide a description of the person's back or organization's background and the reason why we believe they're worthy of the recognition. Moving on to item 15, old business, MHSA, BHSA work group, BHAB members. I don't believe there's a report. And so we will table that till next meeting. And moving on to item 16, contracts. And Cheryl, as you'll notice that there's at least 6 MOUs as far as mentor inpatient, mentor intern programs, as well as intern recruitment related to, looks like 6 different institutions of higher learning, including the ones here in the county. So
Just great. I was talking more about the part before the yeah, this is pretty.
and then, so that's item 16 with respect to contracts. There's 8 total listed here. Any questions? As to that item. All right, moving on to item 17, public comments. Elizabeth Stone.
Yeah, I understand that since I'm not there in person, I am considered public, and so my comments can be ignored. But I still would like to know, what's the status, like, who in the BHAB is being invited to the interviews for the VCBH director position? And can we just get an update on, is Barry in fact retiring? What is the timeline? Why is that position on the county website? Is anyone from the BHAB going to have impact on that, since that person oversees behavioral health services, et cetera? Is there any way to get any information publicly stated on any of that, please? Or we're going to maintain the black box. So maybe this is why the public is hesitant to get involved.
Thank you. Any other public comments? Jerry.
Try not to limit. I actually, I put in clarification, on whatever myself earlier when we had voted for the minutes of the February meeting, I voted, yes. And I realized I should have abstained as I was not present. So if we can make a correction, to the minutes. Thank you.
Thank you. I still believe we have a quorum as to that nonetheless, so a motion to approve minutes still carries, still passes. Thank you. Thank you. Thank you for that clarification. All right. It is, looks like it is 3:12 or 3:11, excuse me, and motion to adjourn. Thank you, everyone. Be well. Bye.